And you diagnose pancytopenia when there is decreased RBC, WBC and platelets. When all the three lineages are decreased, it is called as pancytopenia. That is how we identify pancytopenia. Okay, so pancytopenia can be of two types, with hypocellular bone marrow and normocellular, it is cellular bone marrow. So there is a large list of hypocellular bone marrow and bone marrow pancytopenia and cellular bone marrow pancytopenia. So what are the causes of hypocellular bone marrow pancytopenia? So it is acquired aplastic anemia and constitutional aplastic anemia, and like constitutional aplastic anemia, like Fanconi's anemia and dyskeratosis congenita. Okay, then so some other causes are there, and then pancytopenia with cellular bone marrow. So primary marrow diseases like myelodysplastic syndrome, myelofibrosis, next myelonoptosis and PNH and hairy cell leukemia. And then so cellular, next it is pancytopenia with cellular bone marrow. Now, some other systemic, so primary bone marrow diseases are this one, and some systemic diseases can also cause, that is pancytopenia with cellular bone marrow, SLE, hypersplenism, B12 deficiency, folate deficiency, copper, alcohol, HIV infection, sarcoidosis, TB, sepsis, so leishmaniasis. So there is a large list. So whenever there is pancytopenia, and if it is hypocellular, we look for acquired aplastic anemia and constitutional aplastic anemias and some other disorders, but most commonly we look for acquired aplastic anemias and constitutional aplastic anemias. And when there is pancytopenia with the cellular bone marrow, the causes may be primary marrow diseases like myelodysplastic syndrome, myelofibrosis, myelonoptosis, PNH and hairy cell leukemia, and and systemic diseases like SLE, hypersplenism, B12 deficiency, folate deficiency and copper. So how to differentiate these ones? How to differentiate the when there is pancytopenia, we go for the bone marrow and we look for splenomegaly. If splenomegaly is absent, it is definitely aplastic anemia. The aplastic anemia may be constitutional or maybe acquired. It is definitely aplastic anemia. If splenomegaly is present, the conditions may be peripheral dysfunction like hypersplenism or hairy cell leukemia or myelodysplastic syndrome or myelofibrosis. Storage diseases like Gaucher, Niemann-Pick disease. So, if splenomegaly helps to confirm aplastic anemia. If splenomegaly is absent, it is definitely aplastic anemia. Aplastic anemia. So, aplastic anemia. So, it can be constitutional or acquired. Constitutional or acquired. So aplastic anemia can be acquired or inherited or constitutional. So acquired or constitutional or inherited causes are Fanconi anemia and dyskeratosis congenita, Squamman-Diamond syndrome, and familial aplastic anemia. Let's know something about this Fanconi anemia. So this Fanconi anemia, it is sometimes is mostly a autosomal recessive disorder. Sometimes it is X-linked recessive. So there will be a positive family history. So how will the presentation? The presentation is usually it is presented in childhood. Pancytopenia. So presentation is pancytopenia with short stature, radial ray anomalies, skin hyperpigmentation, capillate spots, and genitourinary renal structural abnormalities, and craniofacial abnormalities like microcephaly, ophthalmic, that is microphthalmia, gastrointestinal malformation like esophageal atresia. Okay, and sometimes cardiac malformations. So what are the features of Fanconi anemia? Pancytopenia with family history, that is autosomal recessive. So there will be short stature with capillate spots and with skeletal abnormalities of short stature and also radial ray anomalies and capillate spots and renal structural abnormalities, sometimes microcephaly and microphthalmia and esophageal atresia and cardiac malformations. These are the clinical features of Fanconi anemia. Fanconi anemia, some important point is it is a pre-malignant condition. It is a pre-malignant condition. It can lead to MDS or AML. It can lead to myelodysplastic syndrome or AML. Patients with Fanconi's anemia are at increased risk of developing solid tumors, particularly squamous cell carcinoma of the head and neck and GIT, skin and GIT. So this is about Fanconi's anemia. Next, coming to Squamous-Bellman syndrome. So what are the clinical features? There are only two features. Pancreatic insufficiency, that is exocrine insufficiency with pancytopenia with short stature. Usually constitutional syndromes, constitutional aplastic anemias are usually noticed in childhood only, almost in childhood. They are found in childhood, and we can see the associated features of the along with aplastic anemia. Okay, that is about constitutional anemias. Coming to acquired anemias. Acquired anemias, that is acquired aplastic anemia. So coming to acquired aplastic anemias, so they can be acquired aplastic anemias can be idiopathic or due to pregnancy or maybe secondary to idiopathic or secondary. Aplastic anemias may be idiopathic or secondary. So secondary may be due to exposure to radiation or maybe due to chemicals or drugs or infections like EB virus. Hepatitis can cause Pancytopenia Aplastic anemia, which is non-A, non-B, non-C hepatitis infection. Okay. Next, infections like Epstein-Barr virus, parvovirus, HIV, and then drugs. So drugs, maybe sometimes direct effects of drugs, sometimes idiosyncratic reactions of drugs. Immune diseases like eosinophilic fasciitis, hypogammaglobulinemia, thymoma, graft versus host disease, pregnancy. So whenever a pregnant woman present with decrease in all three cell lineages, it is acquired aplastic anemia due to pregnancy. So idiopathic and idiopathic. So there are two types of. So acquired aplastic anemia can be idiopathic or due to secondary to some radiation or chemicals like drugs or infections like EBV, parvovirus, hepatitis B. Hepatitis infection can cause aplastic anemia, which is non-A, non-B, non-C virus. Next, so some inflammatory disorders like eosinophilic fasciitis, inflammatory disorders like hypogammaglobulinemia, thymoma, graft versus host disease. So pregnancy and PNH. So these are the various causes of acquired aplastic anemia. So in PNH usually, so sometimes PNH presents, so symptoms of PNH, that is hemoglobinuria, presents early and aplastic anemia presents later. In some patients, in significant amount of patients, first aplastic anemia is seen and then later paroxysmal nocturnal hemoglobinuria will be seen. And infections that are capable of causing pancytopenia, that is acquired anemia, aplastic anemia is acquired aplastic anemia is Epstein-Barr virus, hepatitis viruses, that is hepatitis virus, and parvovirus and HIV virus. So, and then coming to immunological diseases, as I have already mentioned, then I have told about the chemicals. So benzene has been implicated in, but nowadays industrial exposure of benzene has been decreased drastically due to industrial guidelines or strict following of industrial guidelines. Okay, next, how do you treat aplastic anemia? So there are two treatment modalities of aplastic anemia. There are two treatment modalities, mainly bone marrow transplantation, and other modality is immunosuppression. So in adult patients, immunosuppression is the better one. So what is immunosuppression? So immunosuppression is a combination of anti-thymocyte globulin plus cyclosporin. Anti-thymocyte globulin plus cyclosporin is a combination of, yes. Next, coming to the cyclosporin. So overall survival with bone marrow transplantation and immunosuppression is equal. So choice is depending on the age and the severity of neutropenia, and these are the neutropenia and age are the main factors to decide. So to decide the choice of therapy, that it may be bone marrow transplantation or immunosuppression. So both of them are equally efficacious. Next, L-Thrombopag. So recently, L-Thrombopag has been introduced into the treatment and has been accepted, and there is a robust tri-lineage response, that is with L-Thrombopag when it is added to immunosuppression, it is doing well. So L-Thrombopag is the latest treatment modality added to it. So in the supportive care, as we know, supportive care, blood transfusion and all to treat infections and everything, we have to give the supportive care to the patient. So the main treatment modality is bone marrow transplantation and immunosuppression. So both are equally efficacious. Depending upon the age and the level of neutropenia, we can decide which treatment is to be given. So let's summarize pancytopenia. When do you say pancytopenia? When there is decreased RBC, WBC and platelet count, it is called pancytopenia. And then pancytopenia can be hypocellular, can be with hypocellular bone marrow or with cellular bone marrow. When the pancytopenia is with hypocellular bone marrow, we consider it as aplastic anemia. Consider it as aplastic anemia. It may be acquired aplastic anemia, or it may be a congenital, inherited, or constitutional aplastic anemia. So coming to the aplastic anemia. So when there is, and then the other feature we look for is splenomegaly. When the splenomegaly is present, we can definitely rule out aplastic anemia. When the splenomegaly is absent, if it is aplastic anemia. So if there is a splenomegaly, we can rule out aplastic anemia. Splenomegaly is never seen in aplastic anemia. Next, so aplastic anemia can be constitutional or acquired. Constitutional or acquired. So constitutional or inherited causes of aplastic anemia are Fanconi's anemia, dyskeratosis congenita, Squamman-Diamond syndrome, familial aplastic anemia. So let's revise about Fanconi's anemia. So the Fanconi's anemia is a autosomal recessive disorder, and sometimes it is autosomal recessive disorder. What are the clinical features? Short stature and radial anomalies, and cephalid spots, and hyperpigmentation, and microcephaly, microphthalmos, and esophageal atresia, and cardiac anomalies. So, and another important feature is it is a pre-malignant condition. It can cause myelodysplastic syndrome or acute myeloid leukemia. Next, Squamman-Diamond syndrome. So it mainly indicates it contains pancytopenia. Along with that, there is pancreatic exocrine insufficiency and short stature. Okay. Next, coming to the acquired aplastic anemia. So acquired aplastic anemias can be idiopathic or maybe secondary to the radiation, or secondary to chemicals like benzene, or drugs, medicines like non-steroid, non-NSAIDs, and antithyroid drugs. A long list is there. And then infections, that is EBV, hepatitis. The hepatitis, the important point is hepatitis induces pancytopenia, which is non-A, non-B, non-C virus infection. Next, HIV can cause pancytopenia. Infections. So then inflammations, eosinophilic fasciitis, and hypogammaglobulinemia, thymoma, and graft versus host disease, and pregnancy and PNH. And then coming to the treatment of aplastic anemia. Aplastic anemia is usually, aplastic anemia treatment is bone marrow transplantation, immunosuppression, and AAG, and